Director Nicholson, Director Wallace, Director Stewart, Director Cooper, Director Williams. Yes. Presentation. Association, she's a rich systems association. She integrated the area, so for Valley regions. She's a registered nurse with over 25 years of experience in patient care in hospitals around the United States. In her role as the qualified doctor, she works with frontline physicians, nurses, and EMS professionals to improve the care of cardiovascular patients across systems of care using evidence-based methods. We have been a circle program in practice for something for the last almost 10 years now. It's been a good program which has progressed over time. And we see that it's not a simple straightforward program. Maybe just quite as a short program, but it's a multidisciplinary program. Involving the patient, two in the IR, which is our last step, which is going to investigate the divisions. For these 911 EMS system, the emergency room is critical part of this program. The stroke nurses, which is unique to us, which we started off with, keeps the program together. And then the radiologists, the neurologists, and the 4 neurologists that participate in the program are critical, and they seriously have done a great job in making this program successful. Then we have an interventional radiologist program that sits on top of this when we need them. And stroke unit, quote unquote, we've made our 6 West as a stroke unit, and the nurses out there have done a great job. They've learned how to deal with this group of patients, and really helps taking better care. And the rehab, physical therapy, and outpatient sources all comes together, and we meet once a month as a group and listen to everybody's input and improvements that we can bring out in the program. So it's improving on a day-by-day basis. The volumes have been steady. We've competed with the likes of Kaiser's, Sutter's. They have brought in more programs. In the north, we have Eden. In the east, we do not have any programs right now. And the west definitely has Stanford and UC. In the south, we have regional and El Camino. So, but we've kept steady, and I hope we continue to do this. Once, if we go the route of comprehensive, there will be more attractions to our program, but it's not going to make that much of a difference. The exciting thing that has happened this year is the stroke center certification that JACO has come up with. They used to be just primary stroke centers and comprehensive stroke centers. Comprehensive stroke centers were when we could go into the brain and intervene. That is the mainstay of comprehensive stroke center. But now they have brought in 4 designations. One is acute stroke ready hospital. That means they are less than the primary stroke center, but they can take care of acute strokes and transport them. So they have a good transportation mechanism in place. Then the primary stroke center like us and the comprehensive stroke center, they do everything ultimate. The new one that they brought in is a thrombectomy stroke certified, which is really what we are today. That means we intervene. We do thrombectomy programs, which means taking out the clots or opening up the arteries in the brain. We do that, and we've been doing that for years. So we would definitely qualify for that as thrombectomy stroke certified center. The important thing is that we need to go that route because the EMS is gearing up to stratify these patients in the field so that they go to the right place. Because if a patient needs intervention in the brain and you go to the wrong place, it takes at least 2-3 hours, and that 2-3 hours is critical. So EMS is gearing up, and they do things slowly, but they are thinking and trying to risk stratify patients in the field so they go to the appropriate center and save that much time. So we need to start thinking of this this year. This is thrombectomy stroke certified will come in place in January 1st, 2018. As far as the guidelines and measures go, and that is the reason why we are getting the award today, we've done very well. This is over years. We've maintained this. We've been 95% plus. Our goal is 100%, but we miss every now and then, which bothers us, and we review those cases, and we try to avoid making the same mistake again. The other reason that we are getting this award is giving IV TPA within 45 minutes. When we started the stroke program, it used to be 90 minutes. Now, what we are talking about is when a patient comes with a stroke through our ER, the clock starts at that point, and they generally have a blockage in the brain artery. And if we can recanalize or open this brain artery, then we can reestablish blood flow and salvage the brain tissue. And that is the ultimate thing. That's the goal. So the sooner we do that, the better it is. This criteria used to be 90 minutes, then it went down to 75, 60, now it is 45 minutes. That is 50% of the patients that come with acute strokes, we should be able to give TPA within 45 minutes. So the goal is only 50% of the patients. We, as of today, are 70%, and our goal will be 100%, definitely. So we are much better than the target, but still our goal should be much higher. Another thing that we brought about this year, or last year, November, was implementing Code Neuro, which means that when a patient comes with acute stroke, we activate the whole team. The first slide that I showed you, we activate the whole paradigm, the stroke nurses, the ER docs, the lab, the radiology. Everybody gets activated at that one instance, and they are available in the ER to receive the patient and do whatever they need to do. And that is how we can cut down this time of 45 minutes to lower. Believe it or not, our lowest time, Denise, correct me if I'm wrong, is 14 minutes or so. So it's achievable. It is something that we can do it if we have things in place. And you see that when we call Code Neuro, that means we call Code Neuro 61% of the time, 39% of the time we did not call Code Neuro. And we looked at our numbers on that. We found that it was significantly faster arrival to CT when we called Code Neuro, faster arrival and ER assessment, faster lab results, and faster time to TPA. So all these improve when we call Code Neuro. So this is an educational process that we recognize a stroke coming through our doors and calling Code Neuro ASAP. What are our next steps? Basically, continued focus on patient and community education, which we do, and I'm not showing you everything because I want to keep it brief today. But we do a education program at every level. Program focus for 2017-18 is two things. One is arrival to IR within 90 minutes. What I'm talking about now is the IR is the interventional radiology, so that they can go into the brain and open the artery, or at least start the process in 90 minutes. Just to give you an example, for heart attack, we have a goal of opening the artery in 90 minutes.
Over here, we are talking about a goal of starting the case in 90 minutes. So we are still not there. One of these days, we will be there, but that is what our goal is. Today, we are doing it in 3 hours, in 180 minutes. So we need to cut it down to 90 minutes. And the other is to spread our program into the community. Right now, whatever we do, whatever we control is within the hospital boundaries. I think we need to step out into the community and make sure that these patients do better after discharge. And we need to set up some programs on that. The other thing is like what I showed you, we are 94, 95% on our core measures. Would like to be perfect. Target stroke, I showed you we are 70% TPA within 45 minutes. We should be 100%. And we will continue to do stroke research from the hospital database. We have now almost 6,000 patients in our database. So we can learn a lot from ourselves. And that is what we try to do is look at, sort of try to answer questions from our own database. And we do that, we take up 1 or 2 things every year. And we do write up abstracts. We do present them in international conferences on a yearly basis. So we have a lot to do, but we are doing well. Thank you.
Good evening. Thank you, Dr. Jain. Thank you, Nancy, for the introduction. I was the one she was introducing, by the way. So yes, my name is Elena Gunn. I'm the Regional Director for Quality and Systems Improvement with the American Heart, American Stroke, and I met some of you last year. This is the best part of my job because we get to recognize excellence in care. Every 40 seconds in the United States, someone has a stroke, and it is the #1 cause of long-term death and disability in the United States, costing an estimated $30 billion to the healthcare system. And the importance of stroke care, if you think about a stroke, it is a trauma on the inside. It's a trauma that you can't see. But the importance of getting the right care to all patients, no matter where they are, is really the focus of the American Heart, American Stroke Association. We recognize that that requires a team and that requires a system from the moment from the moment when the patient knows to call 911, from the moment the EMS arrive until all the way to discharge. And so when we give these awards, they're recognitions of not meeting 1 or 2 criteria, and certainly it is incredibly difficult to achieve a door-to-needle, door-to-alteplase time of 14 minutes. That is, in and of itself, miraculous, and you should be proud of that. But you do so many other things as well. There are so many other aspects of care that this team is delivering throughout the hospital stay that also not only treat the patient using the best evidence-based practices, but also set things up to minimize the patient's risk of returning with another stroke. So the award I'm giving today is the 2017 Get With the Guidelines Gold Plus Target Stroke Honor Roll Elite Plus Award. So this is, I think it's your 7th year winning. I think it's the 7th year in a row winning the gold, or winning the Get With the Guidelines Award. This is the first year for the Elite Plus. So that really focused on getting patients alteplase in 45 minutes or less. And what does that mean? So that makes a difference between somebody walking out of the hospital and going back to work, or someone being debilitated for the rest of their life. And most of us live and work in our communities. I live in the Bay Area. It's pretty profound that the care that this team does really affects their communities, and that you can feel incredibly confident that your friends and your loved ones and your family, when they come in here, they're going to get the best care that they can give. So again, it is my privilege to present Washington Hospital Healthcare System in Fremont, the American Heart Association, American Stroke Association's 2017 Get With the Guidelines Stroke Gold Plus Target Stroke Honor Roll Elite Plus. Congratulations, everyone. Well done.
I would like to ask a favor. There are a lot of people sitting in the audience right now who've been a big part of the stroke program. Physicians, nurses, managers, doctors. I'd like you to come up here and have your photo taken with this nice lady and our award. Please come join us. Please. Come on, stroke team. You too, Dr. Jane. Doctor, come on. All of you. You guys, Ash, would you please hold it? I'm going to cheerlead over here. Come on, all of you. You should be so proud.
Well, I'd like to express my heartfelt thanks to the whole team that have worked so hard for so many years, and to Dr. Jane's dedicated leadership over those years to create the results which have resulted in this award. It's amazing when you see a patient who's been so helped by the procedures that our stroke team offers. So I'm so encouraged to see that progress continues to be made, and that we're making progress in reducing the time to treatment, because that's so important because time lost is brain lost. So I look forward to next year's award and the year after and the year after, and we continue what a great streak. Thank you so much. All right, let's move on to more.
There is more. Tonight, the second education session is our budget estimate for fiscal year 2017-2018. Tonight, presenting per usual will be Chris Henry and Dan Nardoni. I want to make a few remarks before they take the podium. Estimate is probably the most significant word. Not knowing what's going to happen in Washington, out of the seemingly endless numbers of scenarios that we could be facing, means that we budgeted according to what we know today. And that is that we have an Affordable Care Act. We know that tomorrow, Mitch McConnell will be presenting a draft of a new bill. And the expectation, I believe, is that they'll vote on it next week before they get too close to the August recess. It's anybody's guess what will happen with that, or what compromises may or may not have been made, or whether there are enough votes. Other scenarios have been advanced. One that they repeal the Affordable Care Act and work on replacing it later. Just about anything that's going to happen is certainly raising the level of uncertainty. The Affordable Care Act placed subsidies of the insurance industry in place for 3 years. And at the same time, those subsidies were being dispersed to the insurance industries to encourage them to participate in the exchange markets. The constitutional authority to have authorized those subsidies is now being challenged. Those subsidies have been continued by our current president, again, without any knowledge on our part of whether that's authorized or not. Estimate is the best word I can use. I have told my staff that depending on the changes brought forward and our understanding of them, that we could be back in front of the board of directors almost immediately, bringing forward another budget estimate. These are the most tumultuous times financially in all the years that I've worked in healthcare that I can ever remember. And I think there's probably a lot of people in the room that would agree with me. With that, I'm going to hand the program over to Chris and tell you that he's done a masterful job dealing with uncertainty, and so have the managers that supported him in this effort. Everybody has done their level best to give you what we think is a good budget according to what we know today.
Thanks, Nancy. And you know, as Nancy said, it is a difficult environment to project on, and it seems like it's been that sort of environment really for the last 8 years. You know, during the Obamacare years, the difficulty was, and I love how Donald Pipkin put this a number of years ago. It was like they were building the airplane as it was going down the runway, and now the difference now is that we just really don't know what's going to happen. It's literally changing daily. You know, what you're going to hear, some of what you're going to hear tonight may not be true tomorrow, literally, with the release of the new bill. And so, as Nancy mentioned, we've done our level best to project these numbers based on what we know today. I want to make some acknowledgments before I get started. First and foremost, I want to thank our CEO, Nancy Farber. She is the guiding light for this organization and has provided you know, the vision and the strategic direction of the organization that allows us to produce these numbers. And without your guidance, Nancy, we just couldn't do this. So thank you so much for your help and your attention on this. I want to thank Dan Nardoni, our Assistant Chief Financial Officer. Dan, for a number of years, has been really the master of this budget. Dan manages every aspect of pulling this together and providing numbers that we can all react to and look at and question and validate and all those things. And so, Dan, thank you for your hard work on this. I want to thank the associate administrators and the executive team for working with your divisions and your managers in pulling numbers and bringing them to us to put together and look at. And really the entire management staff of Washington Hospital, this is their budget. This isn't finance's budget. This is a collective piece of work that all areas of management have worked on, and it's truly a team effort that started back in January, and a lot of hard work gone into by everybody involved. So thank you to everybody. This is our mission statement, and the mission statement guides everything we do, including the production of the budget. The budget is the financial underpinning that allows clinicians to go out and perform a mission and provide the services to our community that we provide. It is not just applied to that. It applies to every aspect of the business, including finance. All our financial decisions are made based on this mission and the patient-first ethic, and those decisions are embodied in the numbers you're about to see tonight. So I always like to remind folks of that. It's really an all-encompassing document. It guides every part of the organization. So let's talk a little bit about Republican health care reform. As I mentioned, the landscape is changing daily. It's really difficult to plant your feet on any kind of solid ground when it comes to this. And we're dealing with two bills right now. The House bill, and the way I remember this is the House bill has an H in the acronym. That's how I remember which one is which. House of Representatives in May passed the American Health Care Act. And right now the Senate is wrangling over the Better Care Reconciliation Act. There are differences in these two bills, but but really the way they're getting at healthcare reform really reflects each other. There's differences in the details and how it gets there, but the basic fundamentals of these two bills are very similar. So under Republican healthcare reform, the key component in achieving savings is really aimed at Medicaid funding. They really don't want to mess with Medicare right now. So they're using Medicaid as a vehicle to get their savings, and depending on which bill you're looking at, and this may change tomorrow, the savings that they're targeting are between $772 billion with a B in the Senate version of the bill and $834 billion in the House version of the bill over 10 years based on the Congressional Budget Office scoring. Whichever number it ends up being, it's likely going to affect, in one form or another, all 74.5 million Americans who are covered under the Medicaid program, including over 34 million children, 35 million children, almost 36. It's estimated that if the Republicans are successful, 22 to 23 million Americans will become uninsured. About 14 million of that from Medicaid. So there's big impacts of what's going on right now. There are a lot of people who depend on the Medicaid program to get their health care coverage, and there's a real human cost here that could occur. Funding cuts will, I'm sorry, I need to advance my slides. Somehow we started at the end. So the funding cuts will be achieved through a number of mechanisms. The main target is the Medicaid expansion program that was initiated with Obamacare. They're also looking at the elimination of the presumptive eligibility program. This is a program that assumes eligibility for folks who show up in our emergency room who don't have any coverage. It provides 2 months of free coverage while they're determining eligibility, and that doesn't get taken away. So it really has reduced the amount of uncompensated care that we have performed in the ED, and if they reverse this, that number's going to go back up. One of the proposals in the bill is to cap spending for adults, seniors, children, and really anybody who's covered by the program. Currently, the program matches state spending on Medicaid at 50 cents on the dollar, and with the expansion program, they covered the expansion population at a 1-to-1. And that was to scale down to 90% this year and 80%, and then hold at 80%. The key there is that it's a match up to a upper payment limit. They can't spend more than their budget, but it is a match. Under a cap program, they will fund us a certain amount of money per individual, and that's it. If they go above that, there's no more payment. So that's the difference really between the way we get paid now and how we would get paid under a cap program. The Republican initiative reduces the eligibility cap on tax credits. Currently under Obamacare, people whose income is less than 400% of the federal poverty level receive a tax credit on the premiums they pay for insurance coverage through the exchanges. The House version of this has proposed to reduce that cap to 350% of the federal poverty level, and that may not seem like a big thing, but it really affects the people buying the insurance, and I'll have an example of that to show you in a few minutes. Under both bills, there's a lot of debate around this, but both bills are debating whether or not to go at the protections of pre-existing conditions. Under Obamacare, prior to Obamacare, you know, insurance companies could deny you insurance based on pre-existing conditions. The Affordable Care Act banished that practice or effectively eliminated that practice. Right now, the Republicans are looking at getting rid of those protections. So there's a lot of debate over where they're going to go with that and how far they'll go, but it's on the table. So the interesting thing about this whole thing is while they're trying to save $772 to $834 billion, they want to use that money then to turn around and take on tax reform, in which it's been estimated that they want to produce tax cuts in the amount of about $700 billion. So what are we really trying to do here? We're pulling benefits away from the people who need the most and turning around and giving tax cuts probably to the people who need them least. I mean, it's been assessed that those tax cuts will likely go to the most wealthy individuals in the country and big corporations. So a little bit of reverse Robin Hood economics going on with this set of pieces of legislation. So, you know, all of this will trickle down to California. The good news is that California is still strong. The governor's budget, his May budget revision, contained no change to Medi-Cal reimbursement, although for the first time in several years was a deficit budget to the tune of, as I recall, about $455 million. We did this year get a waiver in California for Medi-Cal, and that waiver included public hospitals redesign and incentive program in Medi-Cal program. This is a pool of money that used to be called okay, let's see if I can remember this. Delivery System Reform Incentive Pool. This was a program that was rolled out to public hospitals and teaching hospitals a number of years ago to provide money, seed money, to provide innovative programs to change the delivery of care. In this last waiver, the District Hospital Leadership Forum was successful in negotiating district hospitals' participation in this, and we're one of the hospitals participating. This program will provide about $3.8 million annually for 5 years to Washington Hospital to fund the startup of our prenatal diagnostic clinic, which is just about to open here fairly shortly, and our palliative care program. So that money is really helping us, and getting into that state waiver is really beneficial to us. The Medi-Cal expansion rollback that the Republicans are talking about will hit California pretty hard. Right now, there are about 4 million adults in California that have been enrolled in the program through the expansion program. California will lose $22 to $24 billion in funding by 2027, starting with $15 million in the first year under the current versions of the bill, which the state is talking about perhaps funding, but I don't quite know where I don't think anybody quite knows where they're going to get the money. So whether that expansion will continue in California really is up to the dollars and cents and where they're going to find the money to do that. The DHCS has estimated that the total funding loss in California as a result of the current bills could be as much as $30 billion. So it's a big financial hit to California and the hospitals that provide care to the Medicaid, Medi-Cal beneficiaries. The California Health Exchange is facing challenges. It's really tough to find out what's really going on in the California Health Exchange. They were, as you recall, we've talked about this before, they managed to get themselves exempted from the Brown Act. But what we do know is insurance companies are leaving the exchanges nationwide. United Health and Aetna have exited California's exchange, as they have most of the exchanges nationwide. That leaves in our exchange Blue Cross Blue Shield, Health Net, and Kaiser as the big insurers. There are a lot of very small plans, but the key thing here is these are all high high copay, high deductible plans that, as you'll see in a moment, aren't necessarily inexpensive. The state right now is projecting premiums to rise 13.2%. It's hard to say what that's going to happen. Last year they thought it was going to go up 8%, and it went up over 12%. So we'll see what happens when they finally announce that. But insurers expect to, if the cuts go through and they stop the subsidies that Nancy discussed earlier, of the insurance companies that have induced them to participate in the exchanges, they're going to ask for up to 19, maybe 20% increases in premiums. So it's already, as you'll see in a moment, not cheap insurance, and the problem's going to get exacerbated. And here's the example. So, and we pulled this information right from the insurance exchange website. This is their analysis. So currently under Obamacare, a family of four making $80,000 a year qualifies for the federal tax credit on the premiums they pay for health insurance. On a bronze plan, which is one of the lower level plans, high deductible, high copay plan, they pay $6,100 a year net after their federal tax credit. Under the House version of the bill, of the Republican reform, that same family of four making $80,000 a year will pay the full $14,000 a year pop for their health insurance on that bronze plan. Now, this is tough on any family. You think about a family of four trying to make it in the Bay Area on $80,000 a year. I mean, this just may make it completely unaffordable for them. So while the insurance is available, for a lot of these folks, it may not be obtainable. So, this is real numbers that come right down to the personal level. This is a small example, but it's just one of many of what may occur if the Republicans are successful with their initiatives. And this is all happening in an environment where there's a basic problem that's been there for years. We've been seeing this slide for years, and that's the fact that government reimbursement for health services already doesn't cover cost. And it's been escalating year after year after year, that shortfall. For fiscal year 2017, our unrecovered cost from governmental payers is over $132 million. That's payment shortfall from cost. Those are big numbers. And the thing that nobody likes to talk about, either in Washington or in California, is the fact that we have to recover that cost somewhere, or we have to close our doors. So what ends up happening is those costs get pushed to commercial payers, who then push it to premium payers to keep the system running. It's a hidden tax that gets pushed to you and me and anybody who pays premiums for health insurance. So that's been a problem for years, essentially from the beginning of the Medicare program. So now they're focusing on this Medicaid piece, which in fiscal 17 for us was $48.8 million shortfall. And that has been a problem all on its own. From 2011 to what we're projecting in 2018, there's been significant escalation in that shortfall, despite all our efforts to cut costs and really control costs. The fact of the matter is that the reimbursement from the programs are not going up as fast as our costs, and that gap widens every year. On top of this, you're going to add for us what amounts to over potentially another $11 million reduction in Medicaid, Medi-Cal reimbursement, and the picture gets pretty ugly pretty quickly. And all of this is going on in an environment here in California and really across the nation. Hospitals all over the country are dealing with different versions of what's happening in this slide. But over the since 2010, we've seen a number of unfunded mandates that we've had to fund, reductions in payment from Medi-Cal and Medicare, including our California seismic requirements. The construction that you see going on across the street is phase 2 of a 3-phase program that we need to complete in order to comply with California seismic regulations by the year 2030. We had an unfunded mandate to install an electronic health care record under meaningful use. And, that was kind of a carrot and a stick program. For a few years, the federal government offered some subsidies to do this, but it came far short of the cost of that. It cost us $86 million to put our electronic medical record system in place, and we've had subsequent upgrades and optimizations, and that will continue to cost us money as we go forward. CMS and Medi-Cal reductions, some large dollars there. Government fees and licenses. Every time we turn around, we're paying a fee to OSHPD, or we're paying a fee to the city, or we're paying a fee. So, they get theirs. To support their organizations. So we've estimated that between 2010 and the current time, all of those things add up to about almost $718 million in reduced income and unfunded expenditures during that period. And as I said again, the proposed Medi-Cal cuts under the current form of the legislation we're estimating could cost us another $11 to $12 million annually. So these are big numbers rolling around that we have to cover. So enough of the bad news. Let's talk about the good news. And there is good news. We like, when we get to this time of year, to go and look at some of the economic projections that the East Bay Economic Development Alliance makes. And they're a group that works with Beacon Economics to really focus on what's going on in the economy in the East Bay. And based on their latest report, there's a lot of good news. They expect employment to continue to grow through the end of the year at a 2 to 2.5% clip, which is good for the district and for the East Bay. Unemployment continues to fall. In the East Bay in general, unemployment numbers are about 4.1%. Here in the district, 2.8%. So we're essentially at full employment in the East Bay, and you can feel it in the labor market. The labor market's tight. It's tough to find people to go to work, and anybody who's been trying to hire lately has felt that. That 2.8% is down from a peak of 9.7%, as we were going through the Great Recession. So there's been great improvement in employment. I think the takeaway here is, even though employment has come back, a lot of people are working 2 and 3 jobs, 2 and 3 part-time jobs. So they don't necessarily get benefits with those jobs. But the good news is they're working. It's good for everybody in the district. And overall, Beacon and the East Bay Economic Alliance say that the future still looks good for the East Bay. So that's good news. The other good news is, during all of this, Washington Hospital continues to get recognized for all the really good work that's being done here. And, some of these we're really proud, all of them we're very proud of, but this year we were named one of America's best 50 hospitals. That's huge. We're very proud of that designation, and along with that, we were named as a distinguished hospital for clinical excellence for the 4th consecutive year. I think a lot of that has to do with our magnet status. This year, our nursing folks pulled together a 4-year redesignation for magnet status, which is really kind of the gold standard for nursing programs in the country. This is not a simple process. To do this, they have to pull together hundreds and hundreds of pages of documents documenting our processes and procedures, sending them data to make sure that we're hitting the targets that the magnet program set. explaining what we're doing to transform care in nursing for the betterment of our patients. It is, once we submit that, they read every darn page. My understanding is they read every darn page of it. And then they come and they audit it to make sure that what we said we were doing, we are doing. And they go right down to every staff member to make sure they can speak to this stuff. It's a huge accomplishment, and we're very proud of our nursing division for doing this again. So congratulations to them. Health Grades continued to give us awards. We received a number of awards. And just so you know, Health Grades is a national firm that rates hospitals across the country. So these rankings are national rankings and really significant for us. So we received Health Grades Excellence Awards for our orthopedic program, both our joint replacement and orthopedic surgery program, and again, multi-year recipients for those. We were again named in America, well, if we were one of 50 best health hospitals in the country, we were also one of the 100 best hospitals in the country, and this time for general surgery. That's the 4th consecutive year our general surgeons have accomplished that. We were recognized by Blue Cross and Blue Shield Association as a Blue Distinction Center for Knee and Hip Replacement. And that this is an insurance organization awarding us for really positive outcomes of what we're doing here at Washington Hospital in our orthopedic program. Health Grades gave 5-star ratings to our programs for esophageal and stomach surgeries, our stroke program, which was just recognized earlier in this meeting. We were recognized for our sepsis treatment and treatment of pneumonia, and again, multi-year recipients in those areas. Nursing division continued their work with the Quest for Zero program beta initiatives. They received recognition for their work in the emergency department in OB this year, and again, they continue good work there. We also continued our work on our green initiatives. This year, Practice Green Health recognized Washington Hospitals, again with a Partner for Change award. We've been recognized with that award for a number of years, and we really did a lot of work in our operating room. The operating room recognized for their greening of the OR award, and what they're doing in there is really interesting. A lot of things that are used in the OR really are manufactured for one-time use. You use them, you throw them away. One of the initiatives they've pulled together is they're collecting these items. They're sending them to an FDA facility that remanufactures those things so they don't end up in our landfill and they come back for use again. So that's good work there. They're also doing a lot of work around sorting recyclable materials in the OR. Before they ever leaves the OR, they're sorting recycling from non-recycled materials. So a lot of good work in the OR to achieve that award. So good things going on in this difficult environment for looking forward. But we think we've produced a good budget here based on what we know. We think it's a conservative budget. And so let's get into what some of this entails. So we have provided for total revenue in this budget of $147.9 million. We've provided for the funding of depreciation expense to the tune of $34.3 million. We've provided for funding of contributions to our retirement plan as the board continues its commitment to make sure that plan is funded for our employees. We're setting aside $20 million for that funding for this year. We've provided for the priorities of the strategic map that the board approved in October. We've provided for the debt service on both our revenue and general obligation bonds. We have provided for net income targets of operating income of $15.4 million and a total net income of $36.5 million. That includes funding of $21.6 million of support for our development corporation and its related entities. It allows for compliance with all of our bond requirements and a debt service coverage of 4-to-1. and it provides for new capital spending requests of $11.1 million. Just a quick look at the numbers. We'll get into the details of this as we move along. As I noted, it provides for total hospital net income of almost $36.5 million. The funding of the Development Corporation at $21.5 million, giving us an estimated consolidated net income of just a little bit under $15 million for the year. Our contractual write-offs as a percentage of gross revenue, we're expecting a slight improvement of that at 76.8% of gross revenue. The operating margin for 18 expected coming at 3.1% and a net margin of 7.3%. So we're going to get into the details of this, but first I'm going to invite Dan to the podium to walk you through the volume assumptions, because it's really what drives the numbers and the financials. So Dan, come on in.
Good evening. I just wanted to start by thanking Nancy and Chris for giving me this opportunity to present the volume and the FTEs for the 2018 budget. And I also wanted to thank the associate administrators for their support and patience as we work through the budget process. It's rather lengthy and tedious. So with that, let's get into the nuts and bolts, which we start with the volume. Everything is based on the volume that we're producing here. All right, we'll start with admissions. We're anticipating a slight increase in admissions to 12,311. The majority of this increase really coming in growth in our oncology and neurosciences programs. We also have additional cases here for our gastroenterology surgeries, along with our non-vascular interventional radiology surgeries. Patient days of 61,578 are anticipated to increase by about 1.5%, giving us an average daily census of 169. This is really due to the cases that I just mentioned in oncology, neurosciences. The outpatient observation days of 2,405 are expected to decrease about 7.4%, which is kind of following the trend that we've been experiencing over the last 6 months or so. Patients having come in through our ED are now treated in a dedicated ED observation unit. And they're treated by hospitalists that specialize in this area. And what we found is, over the 6 months, is that it's led to a reduction in the length of stay of our outpatient observation patients. So we've actually incorporated that into the budget. Average length of stay for the year, we anticipate at 5.00, about an increase of about 2%. That coming in the areas of neurointerventional radiology and neurosurgery, as those cases tend to have much longer lengths of stay. Deliveries of 1,833 reflect an increase related to the opening of the prenatal diagnostic clinic, which we're hoping is going to happen very shortly here. And, with the enhanced coordination of care provided by the prenatal diagnostic clinic, along with our OBGYNs and the special care nursery that opened in 2015, this really will allow us to see high-risk mothers and babies that historically have had to go outside the district to be born right here at Washington Hospital and cared for here. So we're very much looking forward to that opening. Surgical cases are increasing about 1% to 4,549. We're seeing increases in neurosurgical cases of about 5.2% as we continue to grow that program. We're also expecting increases in general surgery, and in particular within general surgery, gastroenterology cases and some oncology surgical cases. We are expecting that joint replacement cases and cardiac surgical cases will remain consistent with 2017 volumes. Cath lab procedures are expected to decrease just slightly in 2018 to 4,027. As you know, historically, cath lab has been centered around the cardiac service line. And however, as we've been watching Chris present his pie chart each month as his financial presentation, we've noticed that that really isn't the case anymore. Cardiac procedures are still a large part of that pie. However, peripheral vascular, neuro, and non-vascular neurointerventional radiology cases collectively have really become the majority of the activity that's happening in the cath lab today. So we are anticipating a slight decrease in cardiac procedures, as we've been seeing a trend of cardiac patients that historically would have been seen in the cath lab are really being treated now medically. So we're bringing those procedures to 1,688. We're also anticipating that peripheral vascular procedures will remain consistent with 2017 levels, and that neurointerventional radiology procedures are going to increase about 9.2% as we continue to grow that program. Non-vascular interventional radiology procedures are expected to increase to 725 as we see the trend of these types of procedures continuing to grow. Looking at emergency room procedures, we're expecting 53,325, pretty consistent with 2017 levels. But again, as Chris spoke about with the legislation, this is an area that could really take a hit if any of that legislation was to be put in place. And then our non-emergency outpatient visits are expected to increase to 85,319. This really related to the opening of the prenatal diagnostic clinic, along with the higher volume in the infusion center that we've been seeing over the last 6 months. I went back and took a look at this because I said, wow, how can this be right? But over the last 6 months, we've seen a 60% increase in the overall volume in the infusion center as compared to the same time last year. And really, as our oncology program continues to take off, we expect that trend to continue and have included it here in the budget. Okay, so with that, let's move into our performance indicators. Total FTEs are anticipated at 1,486.6, an increase of about 5.2%. The majority of the increase here is really related to volume and open positions. However, we do have FTEs related to new and developing programs within the budget. The first being our transition of the dialysis service back to Washington Hospital employees. The contracted dialysis services that we've been experiencing have been determined to be unsatisfactory, and the CEO, Nancy Farber, has made the decision to bring that service back in-house. Even though the contracted service was cheaper, we think that we can provide better care to our patients using our own employees here in Washington Hospital. And this kind of struck me that this is really kind of the perfect example of the patient-first ethic. The patient's coming first, and even if it takes a little bit more financial output on our side, it's worth it for them to have a better outcome. So I was happy to hear that. Okay, so now let's move into some of our trends. Oh, I'm sorry, I want to go back one. I apologize. I do have some other areas of new and developing programs that I wanted to speak about. We have new FTEs for the prenatal diagnostic clinic, the expansion of the LEAN program, the oncology program, and our OR training program. In addition to all that, we've got some IT FTEs that are increasing in this budget, and these are people that are already on our payroll here at Washington Hospital, but have been working on capitalized projects. And as they roll off these projects, they come back into into IT operations. These projects include things like the Epic upgrade that just happened. So that's the other addition there. Now we can move into our volume trends. So as you can see, we've got admissions coming up to 12,311, a slight increase over 2017 activity related to those oncology and neuroscience program increases. We aren't expecting a huge increase in this budget for our payer mix. However, this is one of those areas that with this Republican legislation comes through, we could see huge shifts between Medi-Cal and our private pay. But as far as the budget's concerned, we have set it up with pretty much no change. Inpatient days, as you can see, are climbing from 16 and 17 levels based on those cases that we talked about for oncology, neurosurgery, and gastroenterology. Deliveries coming up from 2017 levels to 1,833, really again related to the opening of the prenatal diagnostic clinic. And total surgeries coming up from 2017 to 4,549, and again oncology and neurosurgery really driving the way there. You can see here in emergency room visits, we had quite an increase from 2017, and that was really related to that really harsh, long flu season that we had this past winter. And so we can see that increase, but we actually in the budget are thinking that things may be a little more stable for 2018. But again, the emergency room is another one of those areas that healthcare legislation could have a huge impact. As people become uninsured, these people will end up in our emergency room. And then finally, our outpatient visits coming up to 85,319. And that, again, is related to the opening of the prenatal diagnostic clinic and the additional volume that we're seeing in the infusion center. And with that, I'm going to turn it back over to Chris to go through the financial numbers in the budget.
Okay, so here's the results of all that volume change. Gross patient revenue expected to increase about $13.9 million in this budget. That includes room and board ancillary services revenue increase of about $22.1 million and an offset in outpatient revenue of about $8.2 million. Now, the big driver there in that reduction is the change in the relationship with the physician groups in the ED. Under the current arrangement, we collect on behalf of the emergency physicians, and that we keep that revenue, and in exchange we pay them a fee, and you'll see an offset to the net revenue from this when we get into expenses. It's really a net zero transaction, but it will affect our gross revenue. That amounted to a decrease of about $16.6 million, and that we also have a decrease in cath lab revenue as a result of the volume change there, and a reduction in the observation revenue with the reduction in observation days. But those are offset on the outpatient side by an increase in infusion center volume. That accounts for about $11.6 million of gross revenue. We also have the increase in outpatient surgeries. That was the gastro surgeries that Dan had mentioned of about $2 million. And we expect our prenatal diagnostic clinic to generate about $1.7 million in gross revenue. So net of that is a decrease in outpatient revenue of $8.2 million. Oops, sorry. Contractual allowances this year increasing not even 0.5%, and we expect that to come in at 76.8%, and there's some drivers there. We do have some payment improvements in our contractual arrangements with commercial insurance companies that amount to about $2.9 million in additional payment. That will reduce our contractual write-offs. We also have, if you recall, about 10 years ago, Medicare started clawing back money as a result of hospitals learning to use ICD-9 coding, which at that time expanded the number of codes they had to use from 1,200 to 18,000 very effectively. And it ended up in Medicare payments not being budget neutral. So starting about 10 years ago, they needed to start clawing back about $11 billion across the nation for that. For us, that amounted to between $2 and $5 million a year in those clawbacks. That program is expected to end this year, so we'll see the restoration, we think, of about $2.5 million in net revenue from Medicare as a result of them ending those clawbacks, so that will help our contractuals. You know, pretty good story there. We can use every dime of that money to help with our patients. The provision for charity and doubtful accounts, we expect to increase about $1.3 million. You know, as Dan mentioned, this is an area that, you know, if the Republicans pass their legislation and eliminate funding for the expansion population, that shift we've seen over the past several years from that line up to contractuals will start coming back down to bad debt. Right now, we've budgeted it consistent with what we've been seeing at about 1.8% of gross revenue, and that's what's accounting for that increase. Including our provision for bad debt and charity, we expect total net revenue at approximately $448.9 million. It's an increase of about $6.4 million. Looking at other operating revenue, a couple of big drivers here. One is, I mentioned the end of the federal meaningful use program. There will be no more payments for implementation of our electronic medical record. In fact, last year they began using the stick, and hospitals that don't meet meaningful use requirements will be getting penalized on their payments from Medicare, up to 2%, and that can be a big number for a lot of organizations. The prime project funding, while we're showing a decrease here, what I need to note is that fiscal 17, because they were late in getting this thing started or ramped up, fiscal 17 included a payment that we received for getting our application complete and into CMS. We did, so that belonged to actually fiscal 16 work. We did receive our $8.2 million in fiscal 17, and we expect to qualify for the $3.8 million in fiscal 18. The other revenue line is increasing about, pretty significantly, about $3.9 million. Angus Cochran has informed us that he expects to start passing along some of the money that he's generated through his capital campaign fundraising activities back to the hospital as we start completing and equipping our new building, the Morris Hyman Critical Care Pavilion. So that's good news too, and thank you for Angus for all that hard work. So in all, total other operating revenue expected to increase about $2.5 million for fiscal 18. Okay, so let's get into the operating expenses. We expect about an 8.4% increase in our salaries and wages expense. A lot of that's coming from our contractually arranged wage increases that are ranging between 1.5% and 4.5%, depending on the bargaining unit. Also, the increase in FTEs that Dan mentioned accounts for about half of that. Moving into benefits, the increase of $2.3 million is being driven largely by health and welfare costs. Those continue to go up. We expect about $1.5 million of additional costs for health and welfare benefits. Also reflected in that line is an increase in payroll taxes related to the overall increase in our payroll. So those are the drivers there. Professional fees we expect to decrease actually about 13.5%. And again, this is the new arrangement with the emergency room physician groups. We expect to not be paying out $6.6 million, offsetting the net revenue that we spoke about earlier. So that's a net zero gain. That decrease of $6.6 million is offset by an increase related to a full year of the backstop and pro fees for our oncology program with UCSF. Supplies, we expect to increase about 5% this year. About $2 million of that increase is related to inflation. We're assuming a 3% inflation rate overall with the exception of pharmacy. Pharmacy we expect to increase 8% at a minimum. The pharmacy, Big Pharma has implemented big increases year after year, mostly double digit, and we somehow managed to have a shortage every year of some drug that we have to pay a lot for. So we'll see what happens this year. Right now the projections are 8%. Also, we've got an increase in volume. The rest of that variance really being driven by the increase in volumes and the supplies related to that. Purchase services, we're expecting a decrease of $2.4 million. That's related to the transition of the dialysis program back to Washington Hospital. It will no longer be paying the fees to the company that's currently providing those services. Utilities are expected to increase about 14.5%. We're really expecting some big increases in that area. We're expecting an increase in our electricity of about 3%. Water just got increased 20% by the Alameda County Water District. And likewise, we're expecting an increase in gas of about 10% this year. So we all saved water, and they need more money. So that's the way it goes. We also have a full year of the operation of the garage impacting those utilities this year. So that's what's rounding out that increase. Insurance, we expect to increase about $284,000. Again, that's coming from a full year of insuring the parking garage, which opened last October. And we also expect a rate increase of about 5% on our property insurance. So some big numbers rolling around there this year. Those numbers have stayed relatively flat, but as we continue to grow our campus, the property insurance numbers go up. Marketing and advertising, we're showing $1 million increase here. That is related to the rollout of a major marketing campaign around the various initiatives that we're undertaking with UCSF. We should start seeing those fairly shortly, but you'll be hearing a lot about our relationship with UCSF and Benioff Children's Hospitals. Software licenses and maintenance, increasing about $316,000. That is for licensing and maintenance on an additional data loss prevention systems, the support of a second med carousel that was installed, and maintenance on EMC storage hardware for our data. Other expenses, this includes things like taxes and licenses, rental of equipment, postage, freight. It's kind of a catch-all for small items. Expected that to decrease about $351,000, and that's really related to the purchase of some equipment that the board was kind enough to approve for us this last year that had been leased, and that includes endoscopy equipment and the purchase of some lab analyzers. If you recall, we purchased those fairly recently. So that's that for other expenses. Depreciation, we're expecting an increase of $352,000. That includes $939,000 of depreciation on new equipment and projects, and about $587,000 of depreciation falling off as assets become fully depreciated. And as you're well aware, we use our assets till they're spent. So while they're falling off the depreciation schedule, they may not necessarily be coming out of use. Interest expense for this year decreasing about $1.4 million. A portion of that has to do with the refinancing of our 2007 bonds that we just completed, but it also primarily has to do with our capitalization of interest as the spend on the Morris Hyman Critical Care Pavilion grows. The larger proportion of that interest expense gets allocated to the project. Eventually, when the project's completed, all of that will come back to the income statement. It won't change the cash flow on our interest payments. It's just going to be changed the way it's recognized in our financials. So here's a look at our operating expense distribution. The only real big change here, and it's not really big, but the notable change here is in our labor costs. As our salaries and benefit costs go up, that number has shifted from 54% of our total expenses in this budget to 57%. All the other areas are within 1% of their historical ranges, but with the tight labor market we're dealing with in the Bay Area, and particularly for healthcare personnel, we are obligated to meet the market in our wages and continue to do so. Yeah. that number actually historically has been around 8 or 9% of our expense profile. It will increase significantly if the changes in Washington occur that are being proposed. You know, pre-ACA, our bad debt and charity would run about 3.5% of gross revenue. Right now, we're running at 1.8% of gross revenue. So, you know, it's tough to project because they're not only are they talking about removing some of those benefits that the Medi-Cal recipients are getting through the expansion and through other programs like the tax credit, but they're debating about how much. So it's hard to say how much that number will be impacted, but it will be impacted if that happens. You know, pre-Obamacare, we were writing off to the bad debt and charity, really to charity, you know, as much as $3.5 million a month at its peak. Right now, we're running at about $500,000, and that's because those folks have gotten insurance. So there's a lot of stuff moving around here, and we're just going to have to watch really closely to what happens. You know, I'm sure Donald will be up at the crack of dawn tomorrow morning looking at that bill that's been released and have a report for us tomorrow so we can start thinking about, okay, what does this mean?
Yes.
Yeah, yes. Sorry, Donald Pipkin, not to be confused with our president. I think Donald Trump has already seen it. So, you know, this is one of these things that we're just going to have to really watch closely, and if there are major changes, we're going to have to come back to the board with what we think are reasonable adjustments to the budget. Okay, let's take a look at non-operating income. We expect non-operating income to increase $3.8 million before our unrealized gains and losses. And we don't budget for unrealized gains or losses because, gosh, I sure wish I had the crystal ball that would let me do it. It's just impossible to tell from year to year what's going to happen over a year in the financial markets. Everybody has, you know, I've been saying for years that interest rates can't get any lower. Interest rate, they got to go up. You know, it isn't happening. So we don't budget for those items, but there are some movements in this area. Investment income's increasing about 20%, and that has to do with interest on the $38.5 million of project funds that we just financed through our revenue bond earlier this year. Rental income is increasing about 68.7%, and that primarily has to do with revenue from the Fremont Office Center. Amortization of intangible assets, that's a new item that we've talked about that, again, is a non-cash item, but it's the recognition of certain intangible assets related to the purchase of the Fremont Office Center. We're going to recognize a full year of that amortization this year. And for now, we don't anticipate any bond issuance costs, although I think there'll be discussions about that moving forward. Also our general obligation our property tax revenue that finances the debt service on our general obligation bonds expected to stay pretty stable. That number fluctuates a bit from year to year based on what the county actually collects. Usually they collect a little more than expected, so it may get adjusted when we find out what the actual number is going to be, but we'll let you know when that happens. Take a look at the capital spending that we're going to request this year, and these are all projects that we anticipate bringing in front of the board during the year. For your consideration. Facility projects for the year are expected to be at a little bit over $2.2 million. These buildings require a lot of maintenance. That includes painting of the main facility, potentially a neurosciences office expansion as that program is outgrowing its space. We're looking at a card access control system for our IT closets, digital radiology facility upgrades that are needed, and some AC units, air conditioning units for the Fremont Office Center, which we knew needed to be replaced. IT projects continue to drive a lot of our capital spending. You can see the items here that we expect to bring forward. Projects less than $200,000 includes just a number of smaller upgrades to minor systems, but total IT projects just a little bit under $4.7 million that we're going to expect to request. Equipment runs this organization. We use our equipment till it's used up, but we do have to replace it from time to time. So we expect to request replacements of equipment and new equipment to modernize in the amount of $3.752 million this year. So to summarize, we have total project spending estimated at $7,360,000. Equipment requests totaling $3,752,000 for a total of little over $11.1 million. Budget also is providing for spending on previously requested items. That includes a Morris Hyman Critical Care Pavilion. We expect to spend another $88 million next year on that. That is primarily funded by general obligation bond proceeds, but we're going to get into the equipment portion of that. We can't spend those bonds on equipment, so there'll be some cash related to that. Facilities projects that have already been approved account for about $3.7 million, and pre-approved IT projects a little over $1.2 million, for a total of $92,956,000 in continued spending on previously approved projects. So that is our budget recommendation for fiscal year 2018. Again, these numbers are based on what we know today. As things develop in Washington, we'll be watching closely and responding quickly and coming back to the board for any adjustments to these numbers that we deem might be necessary. So are there any questions?
Questions for Mike? No. Okay. So this reminds me of a builder building a very nice house in the middle of the path of a tornado. And
Yeah.
I just hope that that tornado from Washington, D.C. passes us by and we don't have to reassemble this. But obviously this was done with a great deal of attention to detail and knowledge of what our services are going to be required in the future. So I thank you very much for this presentation.
Thank you.
Okay, we have consideration of the minutes from June 14th, 19th, 20th, and 26th. If I could have a motion for same.
So moved, Mr. President.
And do we have a second?
Second.
We have a motion and a second. Deke, if you could call the roll.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Eapen.
Thank you. Motion passes. At this point, we're going to open the floor to oral communications. And we have one speaker card from a Mr. Mark R. Aldana, Sr. Speaking on community safety. If you could come to the microphone here, please.
Thank you very much for allowing me to speak today, for allowing the community and people like myself to come and talk to the board about things that concern safety. I'd like to first tell you my name is Mark R. Alma Sr. I live in Fremont, California. I've been living here for, 20 years. I've been living in California for about 30 years. I've been a patient here at Washington Hospital probably 3-4 times over the last few years. And I want to tell you that the last time I was here, I was attacked here while I was a patient. I was stabbed in the back twice. I'll show you some pictures. Oh, excuse me. I you these pictures I have, and I actually have copies that I can give to the board members. Can I approach you?
Yes?
Great. On top is a letter from Kimberly Moss denying that the incident ever took place. Attached are also some other information that you'll find helpful. And I'm asking that this board, I apologize, I may not have enough to go around,
Here, you can use this one.
investigate.
You can use this one, sir.
Great. And determine why the security in the hospital here, the compliance officer, as well as Miss Moss, can't seem to figure out what happened or why. So what happened was I had an attack of diverticulitis back on October 5th of 2015. I came to the emergency room and was admitted. And it was probably the next day, probably at late 12, after 12 at night on the 5th, that I was admitted to a room. So on the 6th, everything was fine. I was in a room that had a patient sharing the room with me who was constantly having to go in and out for dialysis. And my bed was close to the door. So a person named Stacy, who I guess is a transport person, came and asked me to leave that room and go to another room. And I agreed because I wanted to comply. While I was in that room on October 9th, at about 3:30 in the afternoon, a person came into my room dressed in blue scrubs with black hair and black dark glasses, framed glasses. She told me her name was Kat and that a doctor had ordered a test and that I needed to roll on my side. And when I did, she stabbed me in the back twice, which is the pictures that you see there. Those pictures were taken about a week after the incident because it wasn't until the 11th that I actually left this hospital. And the pain in my back was so bad, it required me to have a surgery to correct the problem. And I just, it's in my back. I couldn't see it. I'm asking my doctor, what test is this and who ordered it? Not one doctor ordered any test. Nobody could tell me who this person was, why she was in the room, why I have these scars on my back today. I wrote this letter and called to Miss Moss when I first asked the hospital, what's going on? How do I proceed? Ask Miss Moss. So I did ask Miss Moss. You have my email contact and information I shared with her and the subsequent letter she sent me. If compliance, security, human resources can't figure out who comes into your hospital and what they do to your patients, you should fire them, terminate them, find someone who knows what's going on in their own house. These things happened to me here. I had to get a surgery, and nobody could tell me how it happened, why it happened, or who did it. I don't believe it. You have security cameras, you have security, you have nurses. Tell me what happened. Please help me.
Thank you. It's here. It's here, Nancy. Thank you for your comments, Mr. Alma. We'll review this with our staff, and we will respond to you directly.
I appreciate it.
Thank you. If there are no other comments for oral communications, we'll proceed on to written communications from Dr. Achanta. Back in the hot seat. What's going on? I thought you turfed this off to Dr. Choi.
Yes, Dr. Choi is on vacation, so I'm sitting for him. I tried to get to 600 in the medical staff, and I thought by extending it by a month I could do it, but I guess I ran short again this month. But
It only counts in horseshoes and hand grenades, you know.
Anyway, for the credential items, action items for June of 2017, we have a total of 8 new applicants. Jessica, also from MD, Neonatology and Pediatrics. Francisco Brunn, MD, Intensive Care. Suzanne Duppler, DO in Anesthesiology. Karen Garn, PA, with Urology and Dr. Saleh. Yuk Feng Lee, PA with Dr. Begi in Cardiothoracic Surgery. Jamie Rowe, PA in ENT with Dr. Gersten. Nabil Safi, MD, Interventional Cardiology. And Daniel Z, MD in Teleradiology. Of them, Jessica Alsafram, Francisco Brunn, Karen Garn, Yuk Feng Lee, and Nabil Safi have requested temporary privileges. Locum tenens, we have 2 locum tenens, both covering for Dr. Bastash in radiation oncology, David Hawley, MD, and John Lowe, MD. Designation of supervising physician delegation of services agreement. Anna Chun has an additional supervising physician in Dr. Begi, and Chelsea Joshi has an additional supervising physician in Dr. G, who's covering for Dr. Bruce Lin in his absence. Reappointment applications, we have Marjorie Alpert, MD, in Pediatrics, Paul Cheng, MD, Allergy Immunology Medicine, Jason Chu, MD, Pulmonary Medicine, Joseph Deck, MD, Anesthesiology, Sarah Dobbs, MD, Pediatrics, Christine Elias, MD, Rheumatology, Shankar Jameri, MD in Family Medicine, Jeffrey Gregory, DPM, Podiatry Surgery, Alexander Kopelnik, MD, Cardiology, Samuel Lara, MD, Internal Medicine, Edward Meyer, MD, Endocrinology and Internal Medicine, Wanza Poplampu, MD, OB Hospitalist, Sukhwinder Sandhu, aka Goni Sandhu, MD, Gastroenterology, Mona Tafti, MD, Teleradiology, Joshua Van Gompel, DPM, Podiatry and Surgery, Jason Van Tassel, MD, ENT, Wani Velkuru, MD, Rheumatology, Candy Wong, MD, Intensive Care and Critical Care Medicine, and Jacob Wooden, MD, Radiology. Transfer of staff category and completion of proctorship and advancement of staff category, they are essentially the same. And so it's Chiara Espiritu, MD, Pediatrics, Kelly Franco, Nurse Practitioner, Vincent Ray, MD in Ophthalmology, Bernadetta Rowe, Nurse Practitioner, and Lindsay Wysleski, MD, Pediatrics. All of them have completed their proctorship requirements and are moving from provisional to active medical staff and allied health professionals. Extension of proctorship and in the provisional category, Brian Jin, MD, Pediatric Hospitalist, Christina Hobson, DO in Infectious Diseases, Christine Knox, DO in Emergency Medicine, Anna Novotny, PA, are all requesting extension of proctorship. New privilege requests, Wendy Shu, MD, Intensive Care, Critical Care Medicine, and Amy Celia Mogul, MD in Intensive Care, Critical Care Medicine, both seeking additional privileges in moderate sedation. Deletion of privileges, Alexander Kopelnik, MD, Cardiology, is deleting the listed privileges in the column. Sukhwinder Sandhu, MD, Gastroenterology, is relinquishing ERCP privileges. Benito Valencia, MD, Internal Medicine, is deleting critical care level 2, level 3 privileges. And Candy Wong, MD, Intensive Care, Critical Care, is relinquishing pulmonary artery catheterization privileges. Resignations, we have Brenda Shu, MD, Radiation Oncology, is no longer working at Washington. And Paul Wellesley, Emergency Medicine, is only working at the urgent care clinic and not covering the emergency room anymore. So that's my report.
Thank you very much, Dr. Shan. I'd appreciate a motion for approval of the credentialing action items.
So moved.
We have need of a second.
Second.
Second from Dr. Stewart. Dee, if you could call the roll, please.
Director Nicholson,
Aye.
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson, Director Eaton.
Thank you. Motion passes. $599. We'll go to $600 next month, huh? Okay.
I'll invite you back so you can celebrate.
Great. We'll go on to our Service League report. Debbie.
Good evening, everyone. I'll make this as brief as possible. First of all, the gift shop this last month has done very well. I'm very pleased. A lot of hard work, a lot of dedicated volunteers, and I want to thank each and every one of them for all their time and energy and dedication they put into keeping the gift shop open. The volunteers also are starting to be part of the Concerts in the Park series that started, I believe, last Thursday. I'm hoping to be able to go tomorrow after a foundation meeting. The other item is our volunteering. We are really stepping it up in our volunteering for the Nurses Unit Assist This is a new staffing, and it is really taking off. It's been very well received. We have one of our new volunteers, Jim Santos, and he just seems to be a real go-getter. He is really good at it, and he's just kind of just pulling right to there. And I'd like to thank him for his dedication and a new volunteer, as well as all the volunteers. But he's really going to keep it moving and keep everybody going. The other is that we have some new volunteers also that have joined the CJR, which is great, because that's one of those staffing assignments that you really want somebody who's really dedicated. I know one of the volunteers actually is a recipient of knee replacement, so that really gives that personal touch to those going through the system. Orientation not last week, the week before, was quite busy. We had 73 new volunteers come on board. I think that's probably the largest orientation since I've been doing it, and that's been probably 7+ years. But our ER assignments are 20, gift shop was 8, library was 2, the lobby received 30, Nurses Unit Assist was 12, and Better Breathers was 1, making it 73. Our college and high school recruitment was very high. The college was 38 and the high school was 34 with 3 adults. We really like to reach out to our adult community. We really need those adults because a lot of those students come August and September will not be around because they'll be back in school. So we really need our adult volunteers, new adult volunteers. So please spread the word. As for staffing for the volunteers, the numbers were up the hours were up this last month. Adult volunteers, 1,455. The college was 355. Juniors, being high school, 722. Spiritual care, being 253. And trainees, 209, which you can see we have a lot of new trainees. Total hour of 2,984 hours for this last month. And I want to thank all the volunteers because we can't do it without them. I mean, they really, truly do make a difference each and every day. And that pretty much concludes my report this month.
Great. Thanks for the beautiful work. Thanks so much. And it's good to see the growth.
Yes, it is. It's great.
And especially with the youngins.
Yes, and Kimberly, if I could do a shout out to our assistant director, Kimberly McFarlane. She's done a great job at really getting volunteers on board in a very timely manner. And I think that's really important. Because, you know, if you come in and it takes too long, you lose that enthusiasm. Yeah. We don't want them to lose that enthusiasm. We want them to take it and embrace it, and we've got so much growth going to be happening in the next year.
Yeah. Thank you again, Debbie. Sure. Medical staff report, Dr. Chanta.
As I mentioned, we are up to 559 members on the medical staff. We have 344 active staff members. We have 3 administrative medical staff members. We have 17 in the allied health professionals, 87 ambulatory physicians, 4 in the consulting capacity, 28 courtesy physicians, and allied health professionals. Locum tenens, we have 2, provisional active, 83. So the ranks are in the provisional active continue to be healthy and robust. Provisional active allied health professionals, we have 16. and those ranks continue to grow rapidly. Provisional ambulatory, we have 2. Provisional consulting, we have 4. And provisional courtesy, we have 4. Temporary privileges granted for 5, so for a total of 599 on the medical staff. You're one shy. Tim will do it.
Yeah, I'm sure he'll get us over the top there. Okay, we'll go on to our hospital calendar.
All right, we'll start with the film.
Past health promotions and outreach events. On Thursday, June 15th, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Improving Mobility, Flexibility, and Strength Through Body and Posture Awareness. 10 people attended. On Thursday, June 29th, Lucy Hernandez, Community Outreach Project Manager, staffed an information table on health-related programs and clinical services the hospital provides at the Newark Chamber of Commerce Celebrating Business Luncheon event. More than 80 people attended. On Friday, June 30th, Maggie Gooding, registered dietitian, presented a fun, fresh summer cooking demonstration. 44 people attended. The 2017 Central Park Summer Concert Series, presented by Washington Hospital Healthcare System, kicked off on Thursday, July 6th, with an estimated attendance of 3,500. This free 5-week concert series is open to the public and will be held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Washington Hospital will be providing health information and health screenings during this 5-week concert series. Upcoming health promotions and community outreach events. On Saturday, July 15th, from 10 to 1 p.m., Washington Hospital will host a peripheral vascular disease screening event. This free screening includes a Doppler study of the circulation in the legs and an interpretation of results. This event is co-sponsored by Fremont Bank Foundation. Pre-registration health questionnaire is required. Call 800-963-7070 to schedule your appointment. On Thursday, July 20th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, will present Healthy Living Tips on Weight Management. The presentation will include a body fat percentage screening. The Washington Hospital Healthcare Foundation Report. On Saturday, October 14th, the Washington Hospital Healthcare Foundation will host the 31st Annual Top Hat Dinner Dance. This year's gala will be chaired by Debbie Jackson, President of the Washington Hospital Service League. Dr. William Degoni, General Surgeon, Washington Township Medical Foundation, Medical Director of the Women's Center, and Gary Charlin, President and CEO of Masonic Homes. Proceeds from the evening will benefit Washington Hospital's Radiation Oncology Center by supporting the purchase of a new linear accelerator. This treatment modality will increase the hospital's ability to provide advanced radiation therapy to patients right here in our own community. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the Foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the Newark Chamber of Commerce Celebrating Business Luncheon on June 29th. The first annual Luminary Caregiver Awards dinner, hosted by Masonic Homes of California on June 30th, and the City of Fremont 4th of July Parade on July 4th. Washington on Wheels WOW Mobile Health Clinic. During the month of June, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, Fremont Family Resource Center, and the Ruggieri Senior Center in Union City. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of June was 29. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed web pages include employment, about WHHS, programs and services, and volunteers. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a news feed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth Channel 78. During the month of June, Washington Hospital's cable channel 78 InHealth captured new programming, including a health and wellness program titled Stop Diabetes Before It Starts, and a Diabetes Matters program called Diabetes. Is there an app for that? In addition, InHealth aired 2 patient playbook public service announcements titled 5 Ways to Support a Friend with Cancer and How to Be a Better Caregiver, and the June Board of Directors meeting. Awards and recognitions. On Thursday, June 29th, Washington Hospital was presented the 2017 Sustaining Member Partner Award during the Newark Chamber of Commerce Celebrating Business Luncheon. Washington Hospital was recognized for the long-lasting support, involvement, and active participation with the Newark Chamber. Washington Hospital's contribution enhanced the successful achievement of the Chamber's ongoing goals to create a strong local economy and community. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, and YouTube.
It's my pleasure now to introduce the Board of Directors to our July Employee of the Month. And this one was a bit tricky, because this is the self-same employee that arranges Employee of the Month for all the other employees of the month. And I'm talking about Belinda Martin, who is Executive Secretary in the Human Resources Department. She's a really special person. I've known her for a long time now. When she first came to work at the hospital, she worked for Neil Marks. And she's always the first to volunteer to do something and to help out. She has a tremendously positive attitude. Bryant told her, her boss, that there wasn't going to be an Employee of the Month for July. And BB wondered if it was because in the prior month we'd had 2. And so she kind of went along with this, and then he told her that he had a Gemba walk scheduled in HR. And so when all the executives showed up, she just assumed it was a Gemba walk. So they really were able to pull the wool over her eyes on this one, and they did totally surprise her. So that was a pretty special one to be giving this time. She joined our hospital in 2004, and she has a lot of solid friendships throughout the hospital. 6 years ago, when her 5-year-old son cut his hand, she chose to pass the nearest hospital in favor of Washington, bringing him all the way here, knowing he'd receive the best care in the loving atmosphere of her family. And she says, when you're in trouble, who do you turn to? Family. And that's exactly how she feels about the hospital and the employees. Her son, Armand, is now 11 years old, and her daughter, Amani, is nearly 15 years old. And I'm having trouble with those numbers because they were just little kids when I first learned about them. Knowing that the time with them is precious, BB and her husband, Charles, create as much family time as possible, whether taking a trip to San Diego or simply relaxing in their home in San Ramon. They enjoy their family time together, and she feels very lucky to have a job where her coworkers become friends, and her coworkers feel lucky to have BB in her role at Washington Hospital. She's a very special lady. She's truly an asset.
Okay, we'll now move on to our Lean Kaizen report.
Good evening. We have 3 lean certifications to present tonight, but just want to start by saying, as you know, we've started our lean transformation journey in October of 2014. And as we know, this is to really help us as we move towards becoming the high-quality, low-cost provider of choice. And in order for us to really be successful in this journey, we need to have people that are certified in lean. And we've had 3 cohorts of about 25 or 30 people go through that. And tonight we have 3 that we would like to present. But as you know, in terms of the certification that we've sort of talked about in the past, it's a process that everybody would have to, they do go through. It's 12 to 18 months, and it requires the proficiency in lean concepts and have to demonstrate that they understand and are proficient in these concepts. There's both in-classroom education along with taking the time to go through all the different types of Kaizen workshops, and then to be team lead and workshop lead for those Kaizen workshops. To date, we've had 24 people certified, and then so right now this evening we'd like to recognize 3 people for their hard work and that they've gone through in terms of becoming certified. So maybe if I can have Dr. Nicholson and Nancy come up, and we can start with Mark Moran. We've got and a picture. Next, we have Yvonne DeBanga Rhodes. And next, we have Chris Henry. It is. Congratulations to the newest Lean certified leaders.
Okay, we'll now move on to our construction report.
Thank you, Dr. Nicholson. So, still, as you're going to see, progressing nicely in the project. So here's our schedule. We're staying close to schedule. I think officially we're about 9 days behind, which we have over 60 days in flex in the schedule. So that's not a concern so much. There really isn't anything that's changed here from last month when we discussed the loading dock and the completion that has to happen there. So as far as the progress, as you'll note, this is one of the canopies in front that is got more of a finished look. I've had people mention to me, well, gee, this is not a very impressive canopy in the front, and this is not actually the canopy. This is the entryway into the building, and there's actually a canopy in front of this that lays over the top of it. So that'll get completed more near the end of the project as we're working on the roadways, parking, things like that. This shows you the first floor, so there is flooring that's going in the first floor, and that's getting a fair amount of finished work completed there. This is the X-ray control room in the back of the emergency department, and so that also is progressing. This gives you a shot of an elevator, and there's actually a platform there that they're riding up and down, and so that also is moving forward as planned. This shows you the second floor. It's a critical care room, and this is the boom this is the structure that the boom is going to hang on, and you can see they're finishing ceiling and such around that, and you can see gas lines and things like that coming down to the boom. I think last month we saw that the cabinetry was going in the emergency department. Now you can see it's going into the second floor. This is the third floor, so they're showing they're starting to get, they're just starting the early part of the ceiling tile on the third floor. Still a lot of infrastructure, wiring and such going in there. And they are lifting the skylight onto the roof, and we'll start installation. It's coming in, and it'll be in parts. It's not coming in as a single piece and being laid in. So that will be kind of a moment in terms of the overall completion of this project. This is just a penthouse on the top floor. The penthouses are actually plaster, and from most of around the buildings, you can't see them. If you were looking from the elevated walkway, you could probably see the color. They're close to the match on the metal panels. We talked a little bit about this chimney that's over the old central plant and the demolition that's going to occur there. So you can see we've got some containment in place, and they're working on removing that as part of, it's not actually part of the project, but it is one of the make-ready projects for the Hyman Pavilion. So this is our current status. It's moving along. I'm going to repeat basically what I said last time, which is the completion of the building and the timeliness of the completion is not the concern. It's the connections, the loading docks, the walkways, the parking and such as that will go right up to our completion date, and probably will push on those dates. And those are the things that we're concerned about and watching the schedule on. So we did have one thing happen this month, which was the final OSHPD approval on all the parking lots and roadways and driveways into the ED, because we did do some changes there, and so we have that, and that's now being priced. So that's, of course, some of the last work to be completed. Okay?
Right. Thank you very much, Ed. Any questions?
I have a question.
Yes.
Just out of curiosity, Ed, what is the material that you're using for the skylight?
I was gonna quickly say glass, but I'm gonna have to double check on that. I want to make sure I'm giving you the right answer.
Okay.
It is an opaque, glass-like material. I'll double check to make sure it's not safety glass or something like that.
Okay.
Okay.
Thank you.
Thank you.
Thank you so much, Ed. We'll now move on to our quality report from Mary Bowrow.
Good evening. Tonight I wanted to discuss with you our National Surgical Quality Improvement Program 2017 update. This is a database that works closely with the American College of Surgeons to look at basically surgical data and brings it together. It takes the patient population from the medical record and risk adjust it, and then we go through and validate all data that comes in that before we transmit it into NSQIP. And the biggest advantage, or one of the biggest advantages, is that helps us benchmark our surgical program and procedures against other national hospitals that are similar type of hospital and same type of procedures. So currently, this database is continuing to grow. There's 664 hospitals that participate in NSQIP. This is worldwide. On the West Coast, there's 117, most of which are in California, which is about 59. So it's that's a big jump compared to where it's been at before. But some of the history behind how this database got developed is that already goes back as far as the 80s. And basically the Veterans Health Administration started working closely with the ACS to look at a way that they could sort of benchmark surgical data amongst VA patients. And after having some success with that, they started piloting it in private sector hospitals, and this was early 2000s. And then in 2013, our hospital decided to take place with it. And we started doing some training there and started collecting some data and taking minimal steps to introduce ourselves into this database. So from there, we've kind of moved up a level each year with our level of participation. As of 2017, we decided that we were going to expand it pretty significantly, and so we doubled the number of cases that we've been abstracting. Prior years, we were around 840 cases. Now we're up to, our goal this year is to abstract about 1,680 cases, and use that data to really look at procedure-specific variables and operative procedures. And the rationale behind doing this and participating in it is that if you can take the specific procedures that the database requires and really spend a lot of time, we dedicate one full staff member in quality to this, really spend a lot of time pulling out surgical data, looking at it, you can take that and improve outcomes with patients and decrease mortality. So that was really our main goal for starting to expand our participation in it. Currently, the workflow on how we do this is we collect data from inpatient and outpatient units. We follow these patients for 30 days after they have their surgical procedures. We do have a physician surgical champion. It is Dr. Pipkin. He works very close with that dedicated quality nurse. They review cases. They do practice example cases. They discuss the data weekly, and from there, put it into the database. And the quality department system reviews it together, and then we move it on to the chair of the surgery department so that they can share it with other surgeons. We have really worked hard, especially in the last couple of years, to make sure that the person who's abstracting the data has the appropriate training. You have to be careful, especially when you have one person doing it. We have other people who can cover it, but the bulk of it is really on a quality coordinator who's had 8 weeks of training. This is basically web-based training. They have to do all sorts of practice case reviews, again, reviewing with Dr. Pipkin, and then they take an exam, and if they pass that, they can go on and actually do the abstraction. So the specific data that we're collecting has about 3 phases. One is preoperative. So that's sort of how you can get sort of the risk assessment that you're looking at with the patient. How old are they? What is their clinical pictures? Do they have any complications, any comorbidities? What's the lab data coming into before the procedure? So we get a baseline assessment of how that patient is. Then when they move in and actually have the procedure, we abstract all the clinical data from those procedures and sort of come up with a surgical profile for the patient. One of the key parts of this, though, is following these patients after they leave. Again, I said that we followed them for actually about 30 days. We work with the physician, even the attending, the surgeon, everybody to see, did these patients develop infections after they left? Did they get a surgical site infection? Did they have urinary tract infections? Any complications, even something like bleeding? Have they had to go and see a physician? So those things are monitored very closely. Another thing we try to measure is how well did they understand and follow the discharge information we provided at the time of discharge? Because, as you know, when patients are admitted to the hospital, they're inundated with all this information, they're recovering from surgery. Not a lot of the discharge information can sink in the first time that it's presented to them. So in following them and having phone conversations with them and working with their staff, we can make sure that there is, working with the medical staff, we can make sure that they're getting care after and they aren't just sort of dropping off after they have their procedure. This is a wide variety of specialties that we look at. You can see they're listed here. Of course, the majority of ours end up being orthopedic. We look at a lot of knees and hips. This year, we've looked at a lot of cardiac, also neurology. It's a sample. So they can put any specialty in there for a general or vascular surgery from those specialties, which gives us a great look across the surgical service lines. The criteria that we look at for the post-op follow-up is this is an example of the script, which you can't really read it from this distance. Well, this one actually is a little bit clearer. Basically what this is when we call to follow up with the patient, we ask them, have you had any issues? Have you had to go back to your doctor that's unplanned? And if they say no, we sort of have a little bit more of an extended conversation just to see in general how they're doing. But if they say yes, that's when we sort of drill down and say, okay, what were the issues? Did you have to go to the ED? What were the symptoms? Were these things that, were discussed with you prior to discharge and at the time of discharge to see as potential complications? So a lot of it is scripted to help these patients manage their recovery after they leave the hospital. Getting specifically into some of our data, of course, one of the things that we're mostly focused on is morbidity and mortality. That's probably one of the biggest focuses in NSQIP. And for the years for fiscal year 2016, if you're looking at 191 cases, we actually did good. We had a lower observed rate of 30-day mortality and the complications. Only one patient who passed away out of 191. So somebody who came into surgery very ill to begin with and unfortunately passed. And for the overall morbidity complications, the things I've mentioned before, which is like bleeding complications or urinary tract infections, surgical site infections, those sort of things, we had 9 out of 191. So well beneath the benchmark on those. As with anything else, this database is, of course, interested in unplanned all-cause readmissions, which is good because we're looking at that in a couple other formats in the hospital. So it's nice to be able to drill down specifically on your surgical population. And for that, we've actually had a decrease in the all-cause. And this is any facility, even if they go and get admitted in another facility. But on those patients that were monitored for 30 days, we have seen a decrease. We're still a tad above the national benchmark. We're at 5.1% of patients who came back. Be better to be at 4.9 or under, and that's something we're going to be working on in the next year. Because the good thing about NSQIP is it will give you all the information specifically back in a nice report that you can take and share with the surgeon and say, these are the patients who came back, and it breaks down each area of the complications so you could sort of drill down and possibly see the cause of why they came back. Another one is unplanned return trips to the OR. So basically, the intention is to bring them in, get the procedure, not have any complications, and have to take them back. But unfortunately, that does happen on occasion. And for us, in the fiscal year 2016, out of 191 cases, that was 2.7% of patients had to go back for unplanned trip to the OR, and 2.2 this last fiscal year, which is a decrease and put us under the benchmark. So we were happy to see that. Respiratory complications are, of course, another issue amongst surgical patients. In general, the things that NSQIP and the national standard like to monitor are, did the patient get pneumonia? Did they have to be intubated longer or an unplanned intubation? Maybe this is typically a patient who may go to critical care. And also, did they develop any pulmonary embolisms? Those are measures that we've done while on and kept below benchmark. The area that we were trying to focus on last year was how long patients are staying on a ventilator after surgery. A ventilator, as you know, is a breathing device that helps the patient breathe after they've come out and had surgery. The longer that device is in place, the more likely the patient is to develop pneumonia and have other complications. So it's a metric you really want to watch closely. And so basically the standard is if they're ventilated for greater than 48 hours, you should be sort of looking at what happened there and what you could possibly do to prevent it. So we were at about 2.7%, and in fiscal year 2017, we actually came down to 0. We had all these patients that did not exceed the 48 hours. And the interesting intervention that happened at that time is in October of 2016, we did go to our intensivist-led critical care model, which we think could have had some significant impact to that because we have the intensivists there monitoring these patients very carefully and recognizing when they can come off their ventilators and taking some action around that. You could see that outcomes better, which of course then reduces our chance of pneumonia from developing from the ventilator. Other complications that NSQIP looks at, of course, is any patient that could have a stroke after a surgery, which is always a risk factor after surgery. Did they develop a blood clot while they were here, or did they have a heart attack, otherwise known as a myocardial infarction? So for those, we've had less of all three of the complications within our 30-day post-op compared to the NSQIP benchmarks. We're feeling comfortable about those outcomes on the higher risk complications. Wound infections, another big risk factor for anybody who's having a surgery. Trying to keep the wound from being infected is a big focus. We've had some good successes in there. There were no surgical site infections in fiscal year 2017 in any of the sampled procedures that we saw in NSQIP. we did see an improvement from this based on the fiscal year and performance of the national NISQIP average. And this is every type of wound infection. It can be even superficial, it can be deep, it can go all the way to the organ. They look very closely at that. And they use definitions that are very similar to what the CDC uses for surgical site infections. So it's really the standard practice for how we define them. Other infections are things like hospital-associated infections related to C. diff and urinary tract infections. Those have been the focus that NISQIP's had for the last couple of years because, of course, they also recognize that C. diff is increasing nationally, and they want us to be looking closely at that in these patients to make sure that they are not developing it. And so, again, following these patients for 30 days after their surgery for fiscal year 2016 out of 191 cases, it was about 1.1% that developed a urinary tract infection, a little bit of an increase from the prior year, but still under the benchmark of 1.3. C. diff, this is actually in this particular population, we've seen a decrease in last year. It's not much of one. It's 0.5 in fiscal year 2016, and in fiscal year 2017 it came down a little bit. But considering that this area has struggled so bad with C. diff, this was actually something that considered quite a success that these patients did not develop C. diff. A lot of that has to do with the fact that if the surgical plan goes as scheduled and as the surgeon wants it to, the length of stay typically is shorter, obviously, if you're not having complications, which that alone will decrease your risk for getting C. diff. But this group of patients is a little bit of higher risk. So again, if we were to focus on the overall successes that we've seen by participating in this database, so it was definitely a lower unplanned return trips to the OR. Again, no surgical site infections, urinary tract infections, and C. diff seem to be doing well. The best success we've seen so far, though, is probably decreasing these ventilator hours. But what we would like to do now with the database is, I think we're to the point where we have the staff trained. We have a physician champion who's very interested in taking this data with our quality team to the next level, and that would be really sharing it with the surgeons to an extent where it's not just where you bring them the executive summary and you say, oh, these outcomes are actually pretty good. What we would like to do is take it to the next level now and say, let's drill down on these cases, let's trend out any issues that we have and see if we can improve these outcomes even better over the next year. So that should be our focus, and Dr. Hirschkew is taking over as the chair of surgery, and so we'll be sharing this with him and seeing what we can do to make further improvements.
Great. Thank you very much, Mary. It's good to see that data. Any questions for Mary? No. Thank you. Well now, oh my gosh, Chris Henry again. But wait, there's more.
The hits keep coming. Yeah, and actually, we do have a good story for May 2017. We'll jump right in. Our operating indicators for May, our average daily census was about 2.8, higher than our budget expectation at 164.4. We had 190 admissions, 61 above the budget of 1,029. Patient days were 85 above budget at 5,096. And our outpatient observation equivalent days were 66 below budget at 156. That's a good thing. That means these patients are being managed better when they're in the observation unit and not consuming resources or staying any longer than they have to. Average length of stay for May came in pretty close to the budget, a little bit below at 4.62. We'd expected 4.87 day average length of stay. Looking at our operating statistics, our case mix index, which is our indicates the level of the severity of the patients we saw during the month, came in a little bit below budget at 1.509. We had expected 1.566. Deliveries for the month came in at 156. We had budgeted for 170. Surgical cases came in 61 below the budget at 376. That includes our that was driven in the area of general surgery. General surgery volume was pretty low in May. But our joint replacement cases came in 3 below budget, pretty close to budget at 139. Our cardiac cases for the month were 1 below budget at 11. We did 33 neurosurgical cases in May, 7 higher than the budget. Those are long, complicated cases, so that's good. Cath lab our cath lab procedures for the month were 7 above the budget at 372. Outpatient visits, again, this month were lower than we expected at the budget at 7,217. But the emergency room continued to be busy in May. 4,776 visits in the emergency room in May, 218 above what we had expected. Quick look at the cath lab activity again. Kind of mentioned this earlier. Peripheral vascular activity for the month was made up 43% of the total activity in the cath lab in May, followed by cardiac at 31%, and non-vascular procedures and neurointervention. Actually had a pretty busy month for neurointerventions in May. Rounded that out. Looking at our full-time equivalents, productive FTEs for the month came in at 1,274. We had 136 non-productive FTEs in May, giving us total FTEs that were pretty much on budget at 1,410.4. Our FTEs per AOB, that's our full-time equivalents per adjusted occupied bed. This is our productivity measure, came in at 6.36, just below the budget at 6.54. Moving into the financials, first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation that we use for our audited financials. Total patient revenue came in pretty close to budget at $175,872,000. Contractuals for the month came in 75.42% in May versus a budget of 76.32. We did receive a payment on an intergovernmental transfer. This is the program that the District Hospital Leadership Forum was instrumental in getting going, whereby we transfer money to the state to pull down federal dollars that the state does not, because they don't fund Medi-Cal at a rate that pulls down all the federal dollars that are available to us. We received $1.4 million in May, so that helped bring that number down. So we ended up with net operating revenue about $1.5 million above the budget at $43,806,000. Operating expenses for the month came in $762,000 below the budget, largely driven by our salaries and wages. Came in below budget. Benefits came in a bit below budget. That was offset by a supplies variance that was above budget, really driven by prosthetics in the month. That's reflective of the neurosurgical cases. Bad debt and charity for the month came in pretty close to budget, a little bit over, actually. It's the first time we've seen that in a while, at $3,708,000. So we ended the month with an operating bottom line $2.274 million above the budget at $3,982,000. Non-operating income for the month came in actually $78,000 above the budget at $1,760,000, giving us a total bottom line of $5,742,000 for May. So good numbers for the month of May. We'll take a quick look at the Financial Accounting Standards Board presentation of this information. This reflects adjustments that the financial markets might make in our numbers to look at us. They do not change that operating bottom line at almost $4 million. They do pull out the tax revenue that supports our general obligation bonds and any unrealized gains or losses on investments. So we end May from a FASB perspective with non-operating income about $77,000 below the budget at $210,000, and a total bottom line of just slightly under $4.2 million. So either way you look at it, it's still a solid month for May. So are there any questions on May's performance?
Questions? Okay, thank you very much, Chris. Those were good numbers. Nancy?
Okay, we'll talk about the preliminary operations report for June. Gross revenue for June was below budget at $167.1 million, but it was also higher than June a year ago by 3.7%. Our inpatient gross revenue was $4.9 million below the budget at $123.8 million. The outpatient gross revenue was $924,000 below budget at $43.3 million. The major drivers of the unfavorable revenue variance were room and board revenue coming in below budget by $2.5 million, and this was the lower census in the intensive care unit, which has to be one in a row. Unusual, but there it is. And surgical volume was below budget by 15.1%, driving surgical services revenue down by $2.5 million. In terms of our key census statistics, the average length of stay of 4.9 was higher than what we had budgeted. The average length of stay was 11.6% higher a year ago in June. The outpatient observation days were 84 below budget, and that's a 36.4% variance. Actually, that's a good thing for us. The average daily census of 160 was slightly below budget. In June a year ago, it was 13.5% higher. In terms of admissions, we had 1,005, and they came in below budget by 2.9% or 30 admissions. When you compare it to June a year ago, our admissions were 49 higher. Patient days were 4,787, and they were below budget by 1.7%. When you look a year ago in June, the patient days for the month were 13.1% higher. Last June was a lot busier. The opposite. Sorry, I'm sorry. Surgical cases in June of 348 were below budget by 62 cases. We had an unfavorable variance for surgical services revenue of approximately $2.5 million. Compared to the year before, our cases were 32 lower than a year ago. Inpatient surgeries were 39 below budget at 283. The outpatient surgeries were 23 below budget. General surgical cases were below budget by 51, and that's a 22.5% variance. Neurosurgical cases were below budget by 11, and because those numbers are small, that's a 40.7% variance. Cardiac surgeries were below budget by 2. Joint replacement surgeries were above budget by 2. Our cath lab activity, procedures for June this year were 372, 5 cases above budget. When you compare it to June of 2016, we were 40 cases higher. Inpatient cath lab procedures were above budget by 8. Outpatient cath lab procedures were below budget by 3. Cardiac procedures were above budget by 9 in the cath lab, but below last year's volume by 8 cases. Non-vascular interventional radiology procedures were above budget by 5. Neuro-interventional radiology procedures were below budget by 7. Peripheral vascular procedures were below budget by 2. Deliveries for June of 148 came in below budget by 3. When you compared them to a year ago, we were 3 lower. Our non-emergency outpatient visits of 7,089 were below budget by 438. That's a 5.8% negative variance. These visits were also below June of a year ago by 84. Infusion center visits were 130 above budget. Our infusion center has been going gangbusters since the introduction of our 2 new oncologists. It's very busy over there. The diabetes education and lab visits were 296, and those were 10.9% above budget. These positive variances were offset by, once again, our prenatal diagnostic clinic visits not being able to be realized. We have been trying very hard to get the state of California to come and do the licensure survey, and we've been largely unsuccessful in getting them here so far. And we can't open it until they say we can. So we're waiting. This opening has been pushed back repeatedly through the spring. Our x-ray visits and cardiac rehab visits and hyperbaric visits were 645 collectively visits below budget. In the emergency room, we were 296 visits above budget and higher than last year by 304 cases. Our productive FTEs came in below budget by 22.8 at 1,206.4. That's a 1.9% variance. The non-productive FTEs were above budget by 10.6 at 193.7. Total FTEs of 1,400.1 were below budget by 12.2. That's 0.9% variance. The total FTEs per adjusted occupied bed at 6.48 was just slightly better than budget. The Washington Outpatient Surgery Center had 467 cases in June. They came in 31 cases below the budget, 6.2 negative variance, 6.2% negative variance. The clinic visits of 3,437 were below budget by 1,108. That's a 24.4% negative variance for June. Our payer mix. The preliminary information appears to be unfavorable for the month of June. The government-sponsored patient revenue made up 73.7% of total gross revenue. We had budgeted it at 71.4%. And as was previously discussed in the budget presentation, neither the federally sponsored programs, Medicare or Medicaid, cover the cost of care. The HMO revenue was 2.1% of gross revenue, which also was below budget. PPO revenue was 22.7% of gross revenue, which was below budget. We had budgeted it at 23.2%. Private pay revenue was 1.5% of gross revenue. We had budgeted it at 2%. And finally, the days cash on hand for June was 180, an increase of 8 days from the last month, and an increase of 26 days from February of 2017. The days in accounts receivable were 58. It's very good. And there was $456,533 in charity care applications pending or approved in June. You can already begin to see that number beginning to creep up again. The high deductible, high copay plans are just not feasible for members of our community, many of them.
Insurance doesn't always equal access. Okay, thank you very much, Nancy. We have a single action item this evening, and that's item A regarding our budget. And I believe Director Danielson will present.
Mr. President, I move for adoption of resolution number 1182, which is the budget estimate for fiscal year 2017-2018. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operations to promote the charitable and community service mission of the district.
Thank you. Do we have a second? Second from Director Wallace. Any discussion? I think we're all pretty pleased with the budget.
I think it's been explained.
Thoroughly. Thank you. Dee, if you could call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Eapen?
Great. Motion passes. Chris, you have a budget. Nancy, you have a budget.
Thank you. For at least the next 24 hours.
And we'll see what the morning brings.
Kind of strange times.
I know. At this point, we're going to adjourn to a closed session. We're going to reconvene to open session and announce that no reportable action was taken in closed session, and there being no further business before this board tonight, this meeting is adjourned. Thank you.